Dr. Poonam, you can start. Dr. Poonam, you can start.
Yeah, sure. Just a sec. Good evening, everyone. I hope I'm audible.
Yes.
So tonight we'll be talking on the decoding of the corpus callosum and its abnormalities. The word corpus callosum was described by Galen in the 2nd century and means the tough body. It's a main commercial pathway which connects the two hemispheres. And way back in the 15th century, Michelangelo, in the fresco that he painted in the Sistine Chapel of Rome, by the name of the creation of Adams, showed how important the corpus callosum is, because the god of arm was found to be, or has been, people think it was corpus callosum, and the entire picture on top looks like the brain. So tonight, me, Dr. Poonam Tara, who's a maternal fetal medicine specialist in practicing in New Delhi, and my co-coordinator, Dr. Gaurika Sahi, would take us through the various normal and abnormal features of the corpus callosum. We have Dr. Manisha for our first lecture, depicting anatomy with the imaging. Dr. Manisha is a dear friend and is a professor in Lady Hardinge Medical College. She's doing a lot of research in preeclampsia and placental functions. As also, she started the fetal medicine clinic in Lady Hardinge Medical College. We also have Dr. Ramamurthy, who we are all aware of, a fantastic teacher, is a chief patron of the Medical Ultrasound Society of Karnataka, and works in Srinivasa Ultrasound Scanning Center. Thank you so much, Dr. Ramamurthy, to be here and teach us all in this, the discussion that will follow through. So over to Manisha. Manisha, you could share your slides now, please.
Dr. Poonam, you'll have to unshare your screen.
Yeah, so so I'll just share the screen. I think 1 minute.
Yeah. And so I hand over this back to the floor. I don't know yet whether Dr. Manisha has managed to take.
Yes, sir, I've joined. I'll just share the screen. Sorry for this.
Do. As soon as your screen is shared, then I will be quite happy to let you know. Go right ahead and share your screen. Wonderful.
So sorry for this. So good evening, everyone. And I would really like to thank the organizers, SFM and Dr. Poonam, for inviting me. So I would begin. I know all of you must be waiting for Dr. Ramamurthy to talk, but I would just give a prelude, and I would start with talking about the clinical application of anatomy in imaging of corpus callosum. So basically, we have been doing fetal autopsy at our place, and we have done brain autopsies also. So we would like to take those images and to see how we can improve our understanding of the anatomy of corpus callosum. So the corpus callosum, as Dr. Poonam also said, it received its name from its anatomical compactness, and it represents the major telencephalic commissure between the two brain hemispheres. So if we just see this fetal brain of 18 weeks, and just by separating the two hemispheres, we could see white, glistening white corpus callosum in between the hemispheres. So in brief about the development of corpus callosum. So we know that the corpus callosum develops at around 11 to 12 weeks, and it is a very small compact structure. As you can see here, it is a very small compact structure, and it is not visible at around 13 to 14 weeks ultrasounds. So gradually, when it enlarges in size, it becomes visible. Now the commissure plate, which gives rise to the corpus callosum, also gives rise to the CSP or cavum septum pellucidum. So we have to remember that the cavum septum pellucidum and the corpus callosum, they both develop at the same time and from the same commissural plate. So abnormalities of the CSP may be an indirect sign of abnormal corpus callosum. So this is the corpus callosum, which is there, and the CSP, which develops along with it. So at 16 to 17 weeks, it increases in length, and the commissural plate also becomes thinned out, and the CSP becomes comes into shape. So earlier it was believed that the CC, the corpus callosum, develops anterior to posterior, but the recent evidence of serial pictures of MRI has shown that it can be a bidirectional development also. And it has been said that the timing of insult will tell us whether it is partial or complete absence of corpus callosum. So this is a brain of 16 weeks, 3 days, and we can see here a thin corpus callosum being seen in the just in the interhemispheric region. So by 18 weeks, all parts of the corpus callosum, the rostrum, the genu, the body, and the splenium is well distinguished, but it is still very thin. So at 19 weeks, the genu is believed to be 2 mm, but it becomes very thick near term, and the thickness becomes 4 to 5 mm near term. So if we see this figure taken from the Timmer and Trish book, in this we can see that this corpus callosum has become wide and become big, but at the same time, the fornix is being pushed down, and the commissural plate becomes septum, almost like a transparent septum in which we have fluid, and that is the cavum septum pellucidum, and which is formed at the same time. At around 18 weeks, it is being seen on ultrasound also. It is walled off by corpus callosum above and the fornix below. Now, if we see this 3D multiplanar correlation of anatomy, we can see that the cavum septum pellucidum is a rectangle with a width which is less than its length, and it is a comma shaped in sagittal section, and the coronal section, it is again a rectangle. The CSP obliteration starts at 6 months, and it progresses from back to front. By term, the posterior closure occurs in 97% of the cases. In few cases, it might persist, and it is called cavum vergae. The CSP should always be visualized between 18 to 37 weeks. So if it is not seen at 16, 17 weeks, it is completely normal. And if it is not seen after 37 weeks also, it is completely normal. The shape of the CSP is like a matchbox, and it is, so if we compare it with the shape of fourth ventricle, it is in the 90 degrees rotation. So this is normal. And if this thing is here, then it is not normal. And similarly, in the coronal section also, it should appear like this. Now, the anatomy and clinical correlation in the 3 orthogonal planes. The mid-sagittal plane is the best plane to view the complete corpus callosum. So in this very nice figure, we can see that the rostrum which is found at the so the corpus callosum is a thick band, and the rostrum is the inferior part, which attaches itself, and it is attached to the lamina terminalis from where it develops actually. So the rostrum is here. Then we have the genu, which is actually the knee, the curved portion, which moves anteriorly and continues with the body. And then this arches upward and then goes down, and then forms the splenium, which is the rounded posterior extremity. The splenium is related to falx cerebri above and the free margins of the tentorium. As we can see here, the tentorium, slightly seen, is attached to it posteriorly. Now, as we can see here, this is the cavum septum. This is the cavum septum. This is the corpus callosum, and there is a groove in between, which is called pericallosal cistern. So, in this pericallosal cistern is the pericallosal artery, which we generally see to mark the normalcy of the corpus callosum. Now, this is the coronal view, which is considered also to be the very important view. I've taken this from the SWOG guidelines of neurosonogram. So if we are very anterior, that is just behind the transfrontal and the transcaudate plane, we can see the corpus callosum, and we can see very well the anterior commissure also, from where it is attached, the rostrum is attached. So we can see here that, and we come a little bit posterior, then we can see the frontal horns, which are very close to the cavum septum, and it shows that it is normal. It becomes white when it is abnormal, and this is the thalami, which is seen when we come a little bit more posteriorly. So this is an adult brain, in which these corpus callosum fibers are seen. This is the ventricle, this is the foramen Monro, and this is the thalamus, and this is the third ventricle in between. So this is the adult brain, in which the cavum septum pellucidum is actually not there, and it becomes just septum pellucidum. Now this is the axial section, in which again we see the cavum septum pellucidum and the frontal horns, which is very close together, and the thalami is seen here. This is the frontal horns, which are very close to the midline. Again, here we have the thalamus. In the adult brain, the septum pellucidum is there. Now, there is a very nice article by Callan et al., in which they have explained that the cavum septum pellucidum is, of course, this is normal, but they have shown that is this normal or not. So the falx cerebri should never come in between, and it is anechoic cavum septum pellucidum, which is not here. So it has very beautifully shown in that paper that when you are seeing the cavum septum pellucidum, the section should be from here. When you go below, you actually are taking the phonics, and it is not the true cavum septum pellucidum that we are taking. So it should be a little above, so that we see a proper anechoic structure, which is there. So the points to remember are: the corpus callosum is big enough to be visualized on ultrasound at 18 weeks. The corpus callosum and the CSP develop at the same time and from the same commissural plate. Hence, the abnormality of corpus callosum can be the indirect sign of abnormal corpus callosum. Then in the normal fetus, the CSP should always be visualized between 18 to 37 weeks, and the absence before and after it is completely normal. Thank you. And I would like to thank especially Dr. Poonam for helping me. And we discussed many points, what to include and what not to. So I would like to thank her. And this is what is there in the anatomy.
Thank you, Dr. Manisha. The next talk is by Dr. Ramamurthy.
Can I share my screen? Dr. Manisha has to unshare, please. Is my screen seen now?
Yes, yes, sir. Thank you.
Okay. So at the outset, I must thank the Society of Fetal Medicine, Dr. Ashok Khurana, Dr. Gaurika, and Dr. Poonam for having organized this unique evening concentrating only on the corpus callosum. We've had a wonderful start. Dr. Manisha has taken us through the embryology. She's taken us through the essentials of anatomy, both of the corpus callosum as well as that of the cavum, septum, pellucidum, and how they are so closely related to each other. She's also taken us through the pathological specimens and she's given us a brilliant start. So in this presentation of about 25 minutes or so, I will be concentrating only on imaging. As I had talked with Dr. Gaurika, she said, sir, you do imaging. So that is what I have limited myself. It is purely imaging oriented lecture. I've just touched a couple of slides on the genetic background, and maybe just a slide, a fleeting reference, a slide to counseling, because there's going to be a panel later on which is going to take up all these issues in great detail. Now, we know it's the largest neural commissure, and when we say it's a commissure is a white matter tract which is connecting the two halves of the brain. Simple. A commissure has to connect the two halves of the brain. It has to be white matter. So you have the anterior commissure, posterior commissure, the hippocampal commissure, and the corpus callosum. The corpus callosum is the largest commissure that we have, and it's unique to placental mammals. You will not have crocodiles, reptiles, birds having the corpus callosum at all. And it's concerned with learning, cognitive, judgment, memory, attention span, so on and so forth. Now, we've had a detailed discussion on the embryogenesis, and it's bidirectional. The last parts to form are the splenium and the rostrum, and it begins in somewhere in the anterior body region, right? It's complete by 20 weeks. I would always say 20 weeks and not 18 weeks, although embryologically, yes, 18 weeks is right. But by ultrasound, for us to get good images, I need those 2 weeks. So I always would say my cutoff is 20 weeks. So the embryology for me as an imaging person is 20 weeks, right? So what is the methodology? As all of us know, the corpus callosum is an anteroposterior structure which is straddling the midline. So therefore, if I have to see it, it has to be a mid-sagittal section. It's best seen by a transvaginal approach, but that is possible if it's a vertex presentation, the head is down. You may also use transabdominal 3D ultrasound and MR, right? Now, what is the approach? The approach is anywhere along the midline. You could get your transducer through. I've shown you transabdominal transducers here, and in 2 spots, I've shown you transvaginal transducers. So you can go anywhere along this central line, which is the metopic suture, anterior fontanelle, the sagittal suture, and the posterior fontanelle. Along this line, you have a good window and you can shoot your beam through. And when you do this, you get, especially if you're going through the vaginal route, your high frequency vaginal probe will give you exquisite pictures, as you can see over here. Now, when we look at the corpus callosum, we need to understand that the corpus callosum can be seen in many perspectives, can be seen from the front through the metopic suture or from relatively posteriorly through the posterior fontanelle. Now, what does this mean to us? For us as people who are imaging, it means that the part of the corpus callosum that is closest to the transducer is best seen. And this is brought out by these 2 pictures. Here is a mid-sagittal section where I've gone through the posterior fontanelle. And when I go through the posterior fontanelle, you find that the splenium is beautifully defined. You can see the entire structure so very well, so very well. Now, the rostrum and the genu are seen well, but they are a little far away, right? Now, when I come through the anterior approach, you can see that the rostrum and the genu and the anterior half of the body are well seen. Splenium also is well seen, but it is far away from the probe. Now, for the corpus callosum, if you're doing through a vaginal route, it really doesn't matter, but it really matters for the vermis and the posterior fossa. So the posterior approach is always better because the vermis and the brainstem is closer to the transducer, whereas in the anterior approach, you can see how fuzzy the vermis has become and how fuzzy the brainstem has become. So we need to understand that there are different kinds of angles or approaches to insemination, and each approach might bring us a fresh new look at the corpus callosum. Now, oftentimes we are stuck with the fetal head in the fundus, and therefore I can't do my transvaginal ultrasound. On transvaginal ultrasound, getting a sagittal is pretty easy because you're going to hit the sagittal suture or the anterior fontanelle straight on, and then therefore the beam gets into either a sagittal, or if you're 90 degrees rotate, it goes into a coronal approach. But in a transabdominal approach, one needs to hone the skill of how do we move from an axial to a mid-sagittal section. Now, this little diagram says it all. Now, when you do a transaxial plane, your transducer is oriented in this manner. Now, what we need to do is to move the transducer cephalad. And when you move the transducer cephalad, you actually lose your whole brain. You don't see the brain at this point of time. And when you don't see the brain, you move your wrist, should move the probe 90 degrees and get the beam through the midline, right? That would be the kind of maneuver that one should practice on normal, on everyday cases, normal cases, so that you are equipped with this kind of a maneuver when it comes to a case with a potential pathology. Now, when you do this, how does it play out on the monitor? So this clip will show that. I'm starting from an axial plane, transaxial. I've lost it. I've lost the whole skull. And then I move the transducer perpendicular, get the beam through, and lo and behold, you see the corpus callosum and the vermis. Again, losing on axial, moving 90 degrees and gaining on the mid-sagittal, right? Now, this is a very easy maneuver, and one should be conversant with this, because in case one needs to do it, you should have the necessary skills, right? So anatomy, all of us know this, the corpus callosum is a harmonious contour. It's a curvilinear structure. There are no kinks, there are no angles. It's one beautiful flow which is going across from front to back. It is hypoechoic and it's got hyperechoic margins. And of course, we have the rostrum, genu, body, and the splenium, right? Under the corpus callosum, tucked under the corpus callosum, indeed, is the cystic space. And this cystic space is what we call as the CSP, anterior to the foramen of Monro, and the CV, or the cavum vergae, posterior to the plane of the foramen of Monro. Posteriorly, the splenium actually overhangs the tectal plate. If you notice that this is the thalamus, or the region of the third ventricle, then you have the midbrain with its dorsal hump, and that dorsal hump is the tectal plate. You can see very faintly the aqueduct going through, and the splenium actually overhangs the tectal plate. And then you have the ventral bulge of the pons, and this is the vermis riding piggyback on the brainstem, right? So this is important, ready reckoner, to see if the outreach of the normal corpus callosum is overhanging the tectal plate. Once you see the corpus callosum, you can measure its length, and of course you can measure its thickness. You can do the thickness in the coronal plane as well. And of course, you have the color Doppler to map out the pericallosal artery and the very graceful pericallosal sweep. We tend to use Doppler only where our grayscale is not forthcoming that very well. And as a high BMI patient, you're struggling to get your mid-sagittal view. It's a transabdominal approach. And then you can turn your color Doppler on because your color pickup is a little better than your grayscale pickup. And this 20 weeks is a very, very important timeline that I have to remember, because before 20 weeks, I'm not expected, I wouldn't expect to see a spectacular picture of this nature. And to drive the point home, I've got a 17-week fetus showing you the mid-sagittal section, and you have the corpus callosum there, but it's just that anterior small bit. And within the next 3 weeks, you know, it beautifully develops into that wonderful curvilinear structure that we're used to looking at in day-to-day practice. And also below the CV and the CSP, you have this echogenic line, which is the tila choroidae. The tila choroidae is the roof of the third ventricle. Right, and we already heard Dr. Manisha talking about the CSP and the CC being one unit, being an inseparable unit. And therefore, we have to know how these components of the limbic system are actually related to each other. If it's not, in the case of normal CSP, the CC is present and the condition is normal. If the CSP is absent, the CC is absent, complete agenesis. If the CSP is absent, but the CC is present, there's a septal agenesis, and this indeed is the only condition where the CSP and CC talk different languages. If the CSP is abnormal, the CC tends to be abnormal, and you have callosal dysgenesis, partial agenesis, so on and so forth. And there is no situation at all where the CSP is normal, but the CC is not seen. This is simply not possible, right? So let's start off with the complete agenesis of corpus callosum. You can see that it's 0.7, about 0.7% of general population, but about 2 to 3% in developmentally disabled population. You have chromosomal, syndromal, teratogenic, insults like infection, ischemia, which can cause callosal problems in terms of complete agenesis. Associated anomalies, prognosis, of course, is tough, and I'm sure the panel is going to address this. Recurrence risk depends on the etiology. There are two types. The type 1 is the one with Probst bundles, the common type. Type 2 is the one without Probst bundles, which is the rarer type. And for ultrasound, we have the direct and indirect signs. Direct signs, you start with axial, because in the mid-trimester anomaly scan, we do our transventricular and the transcerebellar views, and we also do the transthalamic for measurement. So one of the important landmarks in all these three axial sections is the cavum, septum, pellucidum. In fact, if you notice that it is only the cavum, septum, pellucidum that is a consistent part of the anatomy, which is seen in all the three basic sections in the mid-trimester anomaly scan. So therefore, we need to understand that we have to document the CSP in every case that we do. And in the process of doing that, if I fail to find the CSP, that would be the first sign of trouble, right? And once this first sign of trouble, we need to leave the basics. I mean, we need to do the basic examination in terms of the axial planes, but we have to move on to a full neurosonogram, which is 3 more planes in the sagittal direction and 4 more planes in the coronal orientation. So therefore, let us look at the possible findings that can catch one's eye in day-to-day practice. First of all, absent CSP. And instead of that, I see 3 lines here. The middle one is Fox. The 2 peripheral ones, the lateral ones, are the medial surface of the frontal lobes. The anterior horns are a mile away from the midline, and they are pinched. They look pinched. When I look at the posterior horns, they look rather prominent. So a rather prominent posterior horn, a pinched and a narrow anterior horn gives rise to the classical teardrop shape of the lateral ventricle, which is a hallmark, which is an indirect sign of corpus callosal agenesis, in addition to, of course, the absent CSP. The three-line sign is due to the frontal lobes falling apart. The corpus callosum is actually a binding force keeping the two hemispheres together. When the corpus callosum goes away, they fall apart, and you have CSF which seeps in, giving rise to this characteristic three-line sign here, right? The third ventricle begins to move upwards. The third ventricle doesn't move. The roof of the third ventricle begins to billow out and kind of extend upwards because it doesn't have a restraining force over there. And therefore, you begin to see the third ventricle in the axial section. This is not the CSP because the CSP is much anterior to this. This is right in the middle of the cranium. The CSP is much anterior, closer to the frontal bone. Right, so you see the high riding third ventricle out here. You see a bit of the anterior horn colpocephaly, and when this clip plays out, you see all these features coming into life. Now, with this, I'm going to leave the axial sections with all the stuff I have seen, and I move on to the coronal and then the mid-sagittal sections. So what are the signs in the coronal section? Again, absent CSP. The coronal section which helps us is the transcaudate section. In the transcaudate section, you find that the cavum, septum, pellucidum is absent. The interhemispheric fissure has a free run from the top to the bottom of the cranium. And of course, you see the three-line sign again. You see the anterior horns are far away from the midline. And if you see very carefully, they have a convex out and a concave in direction. That is thanks to the Probst bundles. Now, when you look at a clip, you will see that the colpocephaly is occurring when the coronal section goes cerebellar. And then you have the transcaudate, classical transcaudate section, that's transoccipital or trans, and this is the transcaudate section. You have the steer horn configuration. You have the steer horn configuration. This is the third ventricle. These are the thalami. So it's not the transcaudate, it's the transthalamic that I'm showing you. And here you can see the tela choroidae of the roof of the third ventricle, which is already trying to niggle its way up. And if this grows into an interhemispheric cyst, it would present on one side or the other of the falx cerebri. So this is the coronal finding. And again, in the coronal finding, absent CSP is a stellar sign, and an uninterrupted interhemispheric fissure in the transcaudate is also eye-catching. So is the steer horn configuration of the lateral ventricles. Again, you have a direct sign of CC, which comes in over here. The CSP is not seen, so the CC is not seen because the CC is the roof of the CSP in the coronal section. So again, there is one component, the body of the CC, which crosses across, is not seen. So one direct sign also comes into your coronal sections. The Probst bundles are parked medial to the lateral ventricles. And since they are parked medial, they tend to indent into the lateral ventricle. And that is why you have this concave in, convex out nature. And I've put the navigation dot on this 3D volume absolutely on the Probst bundle. And you can see the dot here on the axial. This entire length of the white matter that you see here is indeed the Probst bundle. Now, what are the indirect signs that you see on the mid-sagittal section? This comes a little later in the third trimester. You will see, of course, the fact that the cingulate sulcus and gyrus is absent. The radiating sulci are present. There's a little bit of interhemispheric cyst, which is making its way into the section there. And when you turn the color Doppler on, you don't find the very elegant sweep that you're expected to see. You can see the pericallosal artery, which goes straight up and then kind of ramifies there. So those are the indirect signs in the mid-sagittal section, right? But what is the direct sign? The direct sign is indeed the absence of the entire corpus callosum, as you can see here. There is no corpus callosum at all. And how do I know it's mid-sagittal? I know it's the mid-sagittal because I see a brilliant picture of the vermis there. That's the brainstem, but there is no curvilinear structure there at all. I can see the tela choroidae, which is the roof of the third ventricle, but not the corpus callosum. And to make things sure, you move the transducer a little to the right and a little to the left. You're sure you're not missing the corpus callosum. In fact, when you do that, you may even see a little bit of an ecogenicity here. That could be a lipomatous material there. And you see the roof of the third ventricle, which has gone up out here, trying to get its way into the interhemispheric fissure. You can translate all those ultrasound signs onto your MRT2 weighted pictures, as you can see in this image. Now, what are the associations? First of all, interhemispheric cyst. As I said, if the third ventricle becomes a little hypertensive, it pushes its roof up and extends into the interventricular fissure, interhemispheric fissure, and that's exactly what you see over here. That's interhemispheric cyst. And when you do a transvaginal picture of the mid-sagittal section, you find again no corpus callosum at all, and you find the cyst sitting right there in the midline. That's the vermis and the brainstem. Now here's another, this is not another case. It's the same case. I'm sharing with you the axial and the coronal pictures. On the axial picture, you will see that the lateral ventricle, the right lateral ventricle has got a wonky margin. It's got a lot of irregularity over there. Then when I come to the coronal section, you find the interhemispheric cyst over here. But what is interesting to us is that the left hemisphere is big, the right hemisphere is small. And when you look at the convexity of the bigger hemisphere, you see a lot of sulcation, which is not present on the right side. At 20 weeks, the cerebral convexity should show no sulcation. There's no sulcation on the convexity at all. In fact, even on the medial surface, it's just about beginning. So you don't get to see such deep sulci. So it's a hemimegalencephaly, polymicrogyria because of the early sulcation, and PNH or periventricular nodular heterotopia. And this clip will also show the same thing in real time. You see the irregular borders here. You see the sulcations happening there. That is the interhemispheric cyst. So it's important in complete agenesis of corpus callosum, and also partial agenesis of corpus callosum, we look at the rest of the brain very, very carefully. The next association is a lipoma, and this is indeed how a lipoma looks. A small little hyperechoic blob there sitting in the midline where the CC should be there. That is a lipoma. Here is a Nomni view of another lipoma, which is actually not only midline, but it has propagated through the choroidal fissure into the lateral ventricles, and it's seen within the lateral ventricles on either side as well, as you can see in this BCI or rendered whatever 3D. This is BCI because I've used an Omni view here with a thickness. Yes, that's a BCI. So if you look at the article in 1993, Dr. Pilu et al., you find that the teardrop ventricle and the absent CSP actually are very, very good predictors of corpus callosal agenesis on the axial section. And this is Dr. Palladini's work in 2013, saying that after 24 weeks, it becomes very easy. The numbers go up, the detection rate goes up, but before 24 weeks, the signs may be subtle. And that is why all of us in our practices at one time or the other have missed picking up complete agenesis of the corpus callosum in the mid-trimestral anomaly scan. And this is one example in my own practice, 18 weeks. This is what I have seen. This is the section which I've stored in my folio for this patient. I've called it normal, and this is the CSP for me, right, which I thought was a CSP. She comes back at 31 weeks, and I'm just devastated. You can see that there's a colpocephaly, there's no CSP there, full-blown case of a complete agenesis of corpus callosum. And that is why I say that until 20 weeks, the corpus, the CSP, may not be brilliantly seen. You might mistake a structure like this for CSP, and therefore, even if a case comes to me at 18 weeks, I always explain to this lady and say that I have to see you at 22 weeks. Since she's come at 18 weeks, I'm not going to call her at 20 weeks. I'll call her back at 22 weeks just to make sure that things are going well within the brain. Now, what about genetics? We have single gene syndromes, we have CNV variant, we have CNV abnormalities, we have chromosomal abnormalities, so on and so forth. And amongst the single gene syndromes, you have various kinds of inheritance. You have mitochondrial disorders, disorders of oxidative phosphorylation, and counseling intensely depends upon whether we have picked up the CACC or PACC in isolated fashion, or whether it's associated intracranial abnormalities, or whether it is associated with any of these entities, right? As an example, I'll just show you two syndromes. Here is a classical picture of colpocephaly, an absent CSP there. And I want you to see the hand out here. There is a postaxial polydactyly, right? So that's a postaxial polydactyly out here with a complete agenesis of corpus callosum. Look at the mid-sagittal picture, a small nose, a long philtrum over there. Not quite convinced about it, so do a 3D and you find that the fetal face indeed looks a little dysmorphic. So put all this together, you're dealing with acrocallosal syndrome. That's an autosomal recessive syndrome, and of course it's an uncle-niece marriage. You can see that this is a second-degree consanguinity, so she has a 25% chance of recurrence in every future pregnancy that she would have. Here is another case which shows you a complete agenesis of corpus callosum. You can see the all the signs on the axial section. This is the mid-sagittal section showing you the absent corpus callosum and the abnormal vasculature there. When I look at the heart, I find that there is a right heart dominance, and when I do an aortic arch view, I find that the isthmus is narrow, so possibility of a coarctation of aorta. And when you look at the genitalia, there is a microphallus which is seen there. So put all together, you might be dealing with a Mowat-Wilson syndrome. Also, remember this case had IUGR. So IUGR is an important component that we need to take cognizance of. Moving on to partial agenesis. Have I overshot my time, Dr. Gaurika? Can I take about 5 minutes more if I've not?
Yes, sir. Sir, please go ahead, sir.
Yeah. Well, we'll move on to partial agenesis of corpus callosum. And partial agenesis is because certain components of the CC are present, certain are not, certain components are absent. And we know that the splenium and the rostrum and the genu are the last parts to form. So the commonest form of partial agenesis is where the splenium may be absent, the genu and the rostrum may be absent, or only the rostrum may be absent, or a combination of this may be absent. When you measure the CC length, it's going to be less than 10th centile, and you need a nomogram for this. And why is it difficult to diagnose PACC? Because the indirect signs on axial section are subtle. In complete agenesis, you have a total absence of the CSP, but in PACC, the CSP is present and it can deceive any one of us, and it can lull us into a state of, complacency, saying that the CC is there. I mean, the CSP is there, so I don't have to worry about the CC. It's not only the presence of the CSP that is important, it is also the form or the anatomy of the CSPs, which is important, and we'll get to that in the next slide. So the CSP is invariably present, and colpocephaly, teardrop configuration, and three-line sign, mild lateral ventriculomegaly may be absent. So therefore, remember, in PACC, your clue is going to come from a CSP which is present, but which is abnormal, right? Now, this will tell us the fact, or this will drive home the fact that the CSP and cavum virgae, as I said, are tucked under the corpus callosum, right? So therefore, if the corpus callosum is nice and long and normal that it normally is, you will find a correspondingly long CSP that you can see here in this picture. Whereas if you have a CSP which is truncated, Here, the splenium and the posterior body are gone. And therefore, your CSP length also is correspondingly shortened. And you can see a short CSP. When I say a short CSP, it is short in the anterior-posterior direction, right? So therefore, this prompted the paper by Dr. Ravi Chowdhury et al., who observed that if you take the length of the CSP divided by the width of the CSP, it should always be more than 1.5. It's a simple concept that he made it objective. We were always using it subjectively, right? So what are the ways in which a CSP can be abnormal? This is normal CSP. Here is a CSP which is shorter than normal. So the anteroposterior length is short, right? I'm just telling you the variations of that matchbox which Dr. Manisha showed us. A broad CSP is where the length is good enough, but the breadth is more than what you expect. It could be a combination of short and broad. This is a small in all, both the width and as well as the length small. Here is a CSP which is long, but which is rather narrow. So all these things must be kept in mind, and our eyes should pick it up and recognize the departure from normal, so that will prompt us to do a full neurosonogram, that will prompt us to do a mid-sagittal section. So an axial section subjective suspicion will have to translate into a mid-sagittal section, a diagnostic section. Okay, now what are the direct signs? So direct signs are pertaining to the entire corpus callosum that you see in the mid-sagittal section. And as we said, the CC length is not 10th centile as was there in the other slide. It is less than 5th centile. I've got to correct that slide. Remember, it is less than 5th centile. Certain parts may be missing. And you also have some indirect signs. The cingulate sulcus, which is parallel to the corpus callosum, is present only in the segment where the corpus callosum is present. Wherever it is absent, the cingulate sulcus simply disappears. And similarly, the pericallosal artery sweeps only till the corpus callosum is present, and then it wanders off. So let's look at a couple of examples. This is a 32-week fetus. This is a 32-week fetus, and I'm showing you the CSP, right? You can see the CSP, which is normal, abnormal. From a mile away, you know it's abnormal. The length is less, the width is more. A very, very abnormal configuration. But look at the cingulate sulcus, beautifully seen. Cingulate is beautifully formed, right? So with this, it's enough for me. I'm going to move on to the mid-sagittal section. And in the mid-sagittal section, you will realize that the corpus callosum is just one linear bit which I am tracing. The genu is not there, the rostrum is not there, the splenium is not there. It's only this bit that you can see here. And of course, you will see the cingulate sulcus very well anteriorly, but where the corpus callosum stops or is abruptly truncated, you find that the cingulate stops and your radial pattern comes in. This is beautifully seen in this case because it's as late as 32 weeks. And in 32 weeks, the sulcal abnormalities come out beautifully there. So this is the still showing you the cingulate, which is seen until the level of the truncation, and then it is replaced. The cingulate is no longer seen. You have only these radial sulci. Here's another example, broader than longer. And when you look at the mid-sagittal view, this is transabdominal, this is transvaginal. Look at the lateral ventricle looking quite normal. The anterior horns quite close to the corpus callosum. There's no moving away at all. But when you do your transvaginal mid-sagittal, the findings hit you in the face. Even if you don't want to see it, you will see it. You will see that the rostrum is not seen, the genu is not seen, the anterior body is a big lump and thick over there, suddenly gets thin over here, and then it moves on to just stop there. So there's nothing in terms of the splenium, there's nothing in terms of genu and the rostrum of the corpus callosum. So this is a dysgenetic corpus callosum. Now let's look at this 23-week fetus, again a broad CSP. I know it's a CSP because the anterior horns are just lateral to the CSP there, but this is enough for me to move into the full sonogram. I tried a transabdominal, and you can see something of the CSP, CC there in the CSP here, but the pictures are not going to be diagnostic. But when I do a transvaginal, you have these exquisite pictures. No MRI will be able to come close to these pictures if you've got your transvaginal settings right, and if you've got your angles right, you can just produce beautiful pictures. You will see that the CC is thick, abnormally thick. There is no genu, there is no rostrum, there is no splenium there. And I know I'm perfect bang midline because I can see a vermis. You can see the primary fissure, fastigium, and the brainstem. And this is a thick and a short corpus callosum, again a callosal dysgenesis, the first prompt coming to you from the broad CSP. Now here is another case. The first picture shows us a small CSP, or maybe not even a CSP, but the parenchyma is thin, it is echogenic. The subarachnoid space, or the pericerebral space, is wide. And here, when I do a parasagittal section, I find a periventricular halo. Look at that thick band of hyperechogenicity. Then you have normal cortex or parenchyma, and then you have the pia out here. So that is a periventricular halo there. And of course, when you look at the mid-sagittal section, you see the CC, it is there, but it's extremely thin, papery thin. A papery thin CC is called a hypoplastic CC, a classical hypoplastic CC here. Again, when you confirm it on the coronal section, you have your thin CC there, you have periventricular calcification out over here, and of course on the coronal you have a cerebellar hypoplasia and an extremely large cisterna magna there, a compensatory large cisterna magna, telling you that this is infection. Now, periventricular halo is classical of fetal infection and atrophy of the cortex. And since the cortex has atrophied, the number of axons crossing across the corpus callosum is less, and therefore the corpus callosum is thin. Here is another interesting case. We had 19 weeks, CSP looking abnormal, and when we did a mid-sagittal section, only a shred of the corpus callosum is seen. You can see the cursors there. That's the VCI picture showing you it's again a good transvaginal picture going through the mid-sagittal section. So we offered her amniocentesis and invasive testing. And remember, when we ask for invasive testing, it's not the karyotype. You can do your fishes for your early relief as far as your common trisomies go, but we always ask for a chromosomal microarray. And in this case, we found a 2.4 MB loss in 6q, the long arm of chromosome 6. And when you go into a literature, you find that in the phenotypic spectrum, you have corpus callosal abnormalities, developmental delay, seizures, and autism. So here is a direct correlation with the database that we have, saying that this partial agenesis of corpus callosum is a known phenotypic effect of this microdeletion that we have seen over here. And we need to look at the parental karyotype for rearrangements, but then the good news is that microdeletions don't recur in pregnancy to pregnancy, unlike single gene syndromes. So in PACC, just like CACC, we've got to look for extracranial, cranial, and of course, in the cranial, you have ultrasound and MRI, which can help you out. So MRI might add about 1 to 5% more findings, but remember, MRI should be taken, should be referred out for MRI only after you have taken ultrasound to the limits. And MRI is becoming exciting now. You have DTI or diffusion tensor imaging and tractography, which is opening up new vistas. We do not know what this new information, the alternative pathways that neuron is. After all, the neuroarchitecture is altered in corpus callosal abnormalities. So therefore, that might give us more insights into what we are dealing with. So coming towards the end of my presentation, whenever we have a CACC or PACC, our first goal is to say whether it is isolated or non-isolated. Now, to say that it's isolated, I've got to look for associated abnormalities within the cranium, without the cranium, do an invasive testing. And of course, if all of these come negative, you've done a good neurosonogram or MRI or both, a TIFA, and you've done a CMA and kept your DNA for storage. If all that comes negative, that becomes truly isolated. And remember, 15% of prenatal which we think is truly isolated, postnatally had other problems as well, right? So a very important point is do not be over enthusiastic to diagnose PACC or CACC, especially PACC, before 20 weeks. I would always buy those 2 weeks and be more confident instead of putting the patient on tenterhooks, saying that, oh, something appears abnormal, come back after 2 weeks. No, I would just keep quiet and do my scan a little later, right? This is the slide on counseling, which I'm going to skip. And of course, this is a good article in 2021 where MRI-based scoring system, gyration, opculation, temporal lobe asymmetry, hippocampi, lamination, basal ganglia, so on. All of these criteria were taken, and of course, scores were given to correlate it with postnatal developmental delay. The global scale index was taken, and correlation was done, right? So nomenclature, complete agenesis, partial agenesis, hypoplasia. Dysplastic CC is any of these that you can see here. Entire length of CC is thick, focal thickening, focal thinning, abnormal contour, and combinations with segmental abscess. So in brief, wait till 20 weeks for assessment. Indirect clues on axial sections, sagittal and coronals are crucial. It's challenge even to the most experienced. Associated findings are important. Fetal MRI is a useful adjunct. Counseling is tough. You will realize that. And neonatal imaging and neurodevelopmental assessment is a must. Thank you very, very much. Thank you.
Thank you, Dr. Ramamurthy, for a wonderful talk. Lovely images and a great run through the entire normal and the disorders of the corpus callosum. Thank you very much, sir. We would now go to the panel discussion, and it's an honor to get Gaurika into the picture. Gaurika would start off with the panel discussion. Gaurika is a radiologist practicing in La Femme and the ultrasound clinic with a special interest in fetal medicine. Gaurika, over to you for the first half of the panel discussion.
Thank you. Thank you so much.
Can we have the trade partner videos, please?
Yes. All right. So we now go on to the panel discussion. Thank you so much for everybody for staying back. I was watching the number of participants very carefully because I wanted to say we have a great panel discussion. And we would be taking you through a few of the common scenarios which we are likely to see in everyday practice. Now, as Dr. Poonam had shared that screen about the creation of Adam Michelangelo, I want to say that this corpus callosum finds its connection in a lot of ancient literature as well. Here, when we read a little bit of, there's this book, Human Physiology, Expression of Veda and the Vedic Literature, where they've likened the corpus callosum to the axe of Parsuram because it balances the neurophysiological function. And even in Egyptian literature, there are people who have likened the eyebrow of the eye of the Horus to the corpus callosum because this is a sign of wisdom. So from here, we move forward. We have already discussed, Dr. Ramamurthy has already discussed that it is a communication between the two hemispheres. It has billions of axons which are crossing it, nearly close to 200. And it is a bidirectional progress it occurs, which has bidirectional progress. This is how it looks on a specimen, and this is how it looks on an ultrasound with the rostrum, the genu, the body, the splenium, and we must take a mid-sagittal view. to be able to understand the corpus callosum over here. The definitions when we talk about corpus callosum, complete agenesis is when it is completely absent. Partial is when it is seen, but it could be short or some part, it may be short on a sagittal plane. Hypoplasia of the corpus callosum is when it is completely intact morphology. However, it is a thin corpus callosum. This is a hypoplastic corpus callosum. Dysgenetic corpus callosum is when it is abnormal in shape. There might be parts which are missing also, and which are present might be too thick or might be too thin, might have a hump kind of a shape. And a hyperplasia of a corpus callosum is a short and a thick corpus callosum. So these are the standard definitions which are now available. And when we pick up an abnormality of a corpus callosum, we must try and categorize our corpus callosum abnormality into one of these things. Although already covered, once again, there is this very good article which is present in Isiorg about how to image the corpus callosum. As discussed, go through the fontanelles and get a sagittal plane, the mid-sagittal plane, and we should be able to see the corpus callosum in that. And turn your transducer to a 90 degrees to get a coronal view of the corpus callosum. Addition of Doppler to see the pericallosal arteries once we are suspecting a corpus callosum abnormality is a must. And specifically in high BMI patients where we are not able to see corpus callosum very clearly, this can guide us about how the corpus callosum is looking. We can add 3D, which can be an omni view or multiplanar views. All these ways of imaging can help us recognize the corpus callosum. For the biometry of corpus callosum to deciding whether it is short, thin, short or hypoplastic, there are multiple articles which are available online. It started in 1993 by Mellinger, who gave these, studied quite a few of these measured normal corpus callosum and gave his measurements over there. We used to follow this for quite some time, but lately Acheron and Acheron has a much larger study. And not only it tells the length of the corpus callosum, it also tells about the thickness and the width of the corpus callosum. Length has been discussed. We measure the length from one end to from the genu to the splenium we are measuring, and these are the normograms. This is the article which is available online, completely free access. So one can access it to know the biometry of the corpus callosum. For the width, we are taking the coronal section and we are going to look in here in between the two anterior horns to get the width of the corpus callosum. These biometries are also available, and thickness now they are available for each and every body part as well. So with this background, we are now going to start with our panel discussion. I've got very prominent people over here, starting with Dr. Ratnapuri, who is the foremost genetist of our country, I feel, and with 130 publications. I mean, I think that's an introduction more than enough for her. Dr. Alok is a leading radiologist here in Delhi, and all of us who are there on the SFM group must be seeing his pictures, which he keeps on sharing with such excellent resolution. Dr. Saurabh is a neuropediatrics, and specifically working at Max, working specifically in pediatric epilepsy. And we have Dr. Sheetal, who's a managing director at the InFocus Diagnostics in Ahmedabad, and where she specializes in fetal neuroimaging, both ultrasound and in MRI. So, Dr. Alok, I hope you're there.
Yes, Gaurika, I'm here.
Okay. So we're starting with this first case. This is a 28-year-old girl. She came to you at a 12-week scan. There is nothing significant in her history. There was no genetic, no medical history, primary girl. What is it that you can comment upon this 12-week scan?
First of all, I would like to thank Society of Fetal Medicine and the organizers, Dr. Gaurika and Dr. Poonam, for inviting me to be a part of this panel. So this was a case of a primary. She had presented for a regular NP scan, and at the NP scan, I did not find any specific abnormality. The nuchal consistency was normal. The intracranial consistency was also normal. The head was of normal shape, and we could see the butterfly signs. The ventricles were not dilated at all. And when we did the double marker test as well, so the first trimester screening, that was absolutely fine. So
you assured the patient that everything is looking good, yes, and that her double marker was also come out to be normal. So patient is quite relaxed. You, yes, called her back at 20 weeks, but because of the lockdown, she couldn't come back. and she finally comes back to you at 23 weeks. Can you please share the findings here?
I would say that it was better that she came back a little late, because otherwise I probably would have missed this abnormality. So at 23 weeks, the biometry appeared absolutely fine. The head was of normal size and shape, and the posterior fossa showed normal cerebellum, the fourth ventricle, cisterna magna, they were all normal. And what caught my eye was that the lateral ventricles, they were a bit dilated. So the diameter was just 11 millimeters. And then I looked the brain very closely, and then I found that the CSP was not visible at all. And then I saw that the posterior part of the ventricle, the occipital horns, they were appearing more dilated than usual, and the anterior part, the frontal horns, they were little pinched and they were widely separated. Next slide, please. So another view, and this shows beautifully the teardrop shape of the lateral ventricles, the anterior horns, the frontal horns, they are appearing widely separated, and the occipital horns, they are dilated, and which gives it typical teardrop appearance. And
So,
yes, and we can also see that there are too many lines in the interhemispheric fissure region in the upper part of the brain, which is also a clue for this abnormality.
so based on this, Dr. Alok, what were you suspecting, and then what were your initial diagnosis based on this?
These are all indirect signs which suggest that there might be a problem with the corpus callosum. It can be a complete agenesis or partial agenesis, but we need to further investigate, which I investigated, and then we reached the final.
So these were the indirect signs of agenesis of the corpus callosum. We saw an absent cavum. We saw the teardrop shape of the lateral ventricles. We saw the interhemispheric fissure. Over here, we could not see the upward displacement of the third ventricle or any interhemispheric cyst or lipoma. But once we pick up these signs, then, as you said, you will do further and you would do a neurosonogram,
Yes.
right? Yes. So I will move on to the neurosonogram pictures which you have shared.
Yes, so the baby was in breech position, so I could not do a transvaginal study, but I could get fairly decent images on the trans-abdominal plane method as well. And on the coronal plane, we can see that the frontal horns, they are widely separated and they are outwardly bowed, which gives them a steer horn appearance or moose head appearance or Viking helmet appearance, as it is called by many names. And then we can see that the interhemispheric fissure, it appears very wide, and it runs all across the brain from the top to the bottom. And it is in the transthalamic range, we can see that it is reaching up to the roof of the third ventricle. So, and on the sagittal plane, it was diagnostic that I could not see the corpus callosum at all in any of the planes, and which was further corroborated when I switched on the Doppler, and it showed that the pericallosal artery did not have the normal usual course. It was not sweeping as it should along the corpus callosum. So all these findings, they are diagnostic of complete agenesis of corpus callosum.
So as has already been discussed, that they have some direct and indirect sign on coronal and sagittal planes as well. Widening of the interhemispheric fissure, which we can see on the coronal plane. The steer-on shape of the lateral ventricles. Interestingly, historical fact, why they have got these multiple names, it depends upon which part of the world you are in. So if you're in England or Scotland, you'll call it the Viking helmet. If you're somewhere close to Texas, you will call it the steer-on shape, or in America, you will call these names. And the direct and the direct indirect sign on direct sign on the sagittal plane would be the abnormal course of the pericallosal artery, the sunray appearance of the sulci sagittal plane, but that would be much later once the sulci and gyri have formed more prominently. And of course, you will not see the corpus callosum. So what else now? You've done a neurosonogram, you've made your diagnosis. What next, Dr. Alok?
So, so because in most of these, almost half of these cases, there are additional findings. and many of them are CNS defects. Detailed neurosonogram is done, and sometimes we can find other abnormalities in the brain, which can be posterior fossa abnormalities like Dandy-Walker malformation, or we can have problems with the sulci and the gyri, which suggests there can be neuronal migration disorders or malformations of cortical development. Then I look at the eyes carefully. I see the septum pellucidum, and I try to rule out there is holoprosencephaly. And then once I have seen the brain and the eyes properly, then we move on to the rest of the body parts, because there can be other defects in the body parts which may suggest a syndromic or genetic association. Most often they are the cardiac or skeletal or genitourinary abnormalities, which can suggest that this is not an isolated problem. This may be syndromic or genetic.
So you did a detailed evaluation, posterior fossa, as you shown earlier also. It was absolutely normal. The heart was looking normal. You've done a very good 3D. The kidneys were normal. The limbs, the hands also, as you had shared, are all looking good. So based on this, what is your preliminary diagnosis?
So in my mind, I was dealing with an isolated absence of corpus callosum. This was diagnosed at 23 weeks, yes.
And would you offer her further imaging? Because I think you've done a great ultrasound.
Yes, fetal MRI is advisable in such cases because first of all, it gives confirmation of your diagnosis, whether and it gives an objective confirmation. And plus, in about 10% of the cases, it may pick up additional findings which may not be seen on ultrasound at all.
Right. So as you requested the patient to go in for a fetal MRI, where the findings are quite obvious. This was a complete agenesis of corpus callosum, and we are able to see the other signs also over here. The steron shape of the frontal horns, the wide interhemispheric pressure, complete absence of the agenesis of complete absence of the corpus callosum. So as you had pointed out, 8 to 12% of cases MRI detects additional findings. And when we do MRI, can be done in two steps. One, it can be done at that time of diagnosis at 23 weeks to see. And then if we have picked up an isolated case of corpus callosum and we do not find any other associate finding and the pregnancy is continuing, we must offer an MRI later in pregnancy to prognosticate it better. That we would be discussing in one of the later cases. So based on your MRI, we had an isolated agenesis of the corpus callosum. You did refer the patient to the genetist, however, she opted for a termination. So to sum up today's case, first case, so agenesis of corpus callosum is seen in about 1.4 of 10,000 live births. However, in children who've got neurodevelopmental disabilities, this incidence is much higher. The most common sign which most people pick up is the absence of the cavum septum pellucidum or the abnormal shape of the cavum septum pellucidum. Therefore, visualizing this is mandatory. And in fact, through Isiog, all the axial planes of the brain is mandatory to document the cavum septum pellucidum. The normal length at about 20 weeks is about 18 to 20 mm. Before this, it is quite less, 10, 12, 15 mm. So it's very difficult to see. At 20 weeks, it would be an ideal sign to look at the corpus callosum. We must look for associated anomalies, both in the CNS. This could be of a migration, posterior fossa, interhemispheric cyst, and extra CNS anomalies, as has been discussed in the heart, in the limbs, in the kidneys. And we must offer MRI at the time of diagnosis for confirmation, because 20% of the cases can be false diagnosis as well, to look for associated anomalies, and later in pregnancy for prognostication. And we must offer genetic test if the patient is planning to continue. Or in fact, we must encourage genetic testing because it can have bearing in future pregnancies also. Thank you, Dr. Alok. So that ends our first case. Dr. Poonam, on to you for the second case.
Yeah, so share the screen. If you want to share the screen, Gorika.
And that.
Am I visible now?
Yes.
Kartika?
Okay. Visible?
So we start with the case 2. Gravida 2 para 1, 36
Poonam,
year
sorry
old.
to interrupt. Will you put it
Yeah.
on the full screen mode?
Okay, sure.
From the bottom right.
Is this better?
Yeah, it's fine.
Okay,
Great.
so the second case is a Gravida 2 para 1, who's a 36-year-old IVF pregnancy. She got pregnant on the 3rd attempt of IVF. The 12-week scan and the combined NT was low risk. The anomaly scan done at 18 weeks was reported as normal. There was no other significant family history or medical history. She had gone to her native place, and when she came back at about 26 weeks, she presented to the following findings at 26 weeks. Dr. Alok, could you just take us through as to what you saw on this transaxial view?
So at the first glance, there is no apparent abnormality in this case. The cerebral parenchyma, it appears normal. There is an interhemispheric fissure. But if we look closely, we find that the CSP, it is appearing abnormal. It is appearing little short and broad in diameter, in the transverse diameter. So this was the finding which is very significant, and it can suggest there may be an abnormality of the corpus callosum. And the ventricles, they were not dilated at all, and the interhemispheric fissure, it is appearing little wider in the hindsight.
So apart from just a suspicious looking corpus CSP, and everything else looked okay, you decided to go for the coronal view and the sagittal view, right? So could you just describe what you could see in the mid-sagittal view?
So in the mid-sagittal view, we can see that the corpus callosum, it appears very short in length for 26 weeks. And we can see that the anterior part appears quite well developed, but the posterior part of the body and the splenium, it is not so well visualized. And normally when we see the corpus callosum at 26 weeks, we should see that it is overhanging the tectal plate of the midbrain. But in this case, it is falling well short of the midbrain tectal plate. So it is not overhanging at all. So it is appearing very short. Otherwise, the morphology looks okay.
So as Dr. Ramamurthy also, presented in his case, that this is not overlying. It should overline the agenesis plate. So you can see it's halfway through. So it looks like the partial agenesis of the corpus callosum. So this is the measurements that you've taken, comparing with the normal.
This is an image for comparison. You can see that at 26 weeks, the corpus callosum should look like this.
Yeah.
The overhanging the tectal plate, but in this case, it is appearing very short.
Yes. So to summarize, just to take you through the various transaxial images, in this you can see a normal rectangular shape cavum, septum, pellucidum. 3 lines suggestive of a complete, as spoken by Gaurika and Dr. Ramamurthy. This is the one where we are concentrating on. And there's a very nice article in the York Journal by Ocean, where it says that if you concentrate on this side, the CSP, this probably is the only sign that we've seen 50%. So you see, this is not as good as this, as the matchbox appearance, and the wider, it's more wider than the length. And what of late I've been starting doing is to look into the more anterior part of the transaxial plane, the transthalamic and the transventricular plane, where I look very carefully, just magnify the image. You should see the entire interhemispheric fissure, which is this. If you magnify it, you can see it. It should be interrupted by the genu of the corpus callosum. And just below it should be the cavum, septum, pellucidum, as you can see here. This is the abnormal CSP. This is again a good article where describing the anterior complex by the Guborg group. There's a distortion of the IHF, which is the interhemispheric fissure. So very important, see the CSP well and make sure that that's so that you don't miss out any agenesis of the corpus callosum, as also the partial agenesis. And as highlighted again, we reiterating again and again the same points. Medial, the proboscis the bundle medially deviate and steer horn appearance, but partial, you see the normal in the coronal plane, the normal frontal horns. However, the genu of the corpus callosum looks small. And similarly, in the sagittal plane, in the mid sagittal plane, the third ventricle is superior in the complete, and the partial, you see a bit of the anterior body of the corpus callosum, and the third ventricle is slightly superior. So what did you offer to her next, Dr. Alok?
So we offered a detailed anatomic survey, as I told earlier. In such cases, we have to look for other abnormalities in the brain and in the heart and limbs and face and the abdomen. So we performed a fetal echocardiography, and fetal MRI was advised in this case, and which showed that, which confirmed the diagnosis that this was an isolated partial agenesis of corpus callosum.
So thank you, Dr. Alok. For the next step, you sent it to for the genetic opinion. So the patient went, Dr. Ratnapuri. So Dr. Ratna, what are the causes of corpus callosum abnormalities?
Hi, good evening, and thank you so much for such a wonderful panel and for having me as a part of this panel. So when we think about causes, I think we would start with non-genetic and genetic, because everything is not genetic. So you would look for a history of teratogens, you would look for a history of intrauterine infections. And when we think about the genetic causes, then we would start with a family history. I noted that this was IVF. So is there a chromosomal translocation? Because chromosomal forms a very important component of abnormalities of the corpus callosum. And in about 10 to 15% of cases, we do get corpus callosum abnormalities that could be either abnormalities of number or structure. And so we do know that the commonest abnormalities of number are chromosome 13 and 18. There are also some reports of mosaic. All of this would be picked up by a microarray, except for a very small percentage of mosaicism. Okay, it has to be below a certain threshold, only then it's not picked up by an array. But additionally, it is known that 40% of the abnormalities that are picked up by a microarray would not be picked up by a karyotype. So it's important to know that. And so the way to go about it is, if we have cost constraints, which we do in our country, so that you do, depending upon the sample you are taking or the lab that you're going to, you look at the 5 common chromosomes, which includes 13 and 18 abnormalities, either by a FISH or a QF-PCR, whatever the lab is good at doing. And then we do what we call a reflex microarray. So if that first report is normal, then you go ahead and do a microarray and to look for the additional structural abnormalities, which are seen in about 6 to 10% of cases. And if the first report is abnormal, then save the money of the patient, don't do the microarray, but do a karyotype instead of the couple to look for a balanced translocation, if there is any, because that is something you would miss on a FISH. So I think that's as far as the chromosomal goes. Then we have the single gene disorders, which are because of genes within the chromosomes. And though we divide it as monogenic and metabolic, most of these metabolic causes are also because of mutations in single genes. But I think the important thing I want to say about this is they would really not have additional malformations. So we always say that if we have a syndrome, we expect some additional malformations beyond the corpus callosum abnormality. But none of these, because these are all metabolic disorders, and if you see the phenotype that is there in the slide, there is nothing: failure to thrive, developmental delays, seizures, metabolic acidosis. There's nothing that you can pick up on the scan. So I think it goes without saying that if your chromosomes are normal, we have about a 30 to 40% yield for single gene disorders, though the data is limited. Most of the data is from postnatal studies. There was a recent paper in 2020 or 21, which is on about 63 fetuses with just abnormalities of the corpus callosum. That's the largest cohort that's reported till now. And their diagnostic yield was 23%, which is also huge, And, so we would do an exome sequencing, and not a clinical exome. We would do an exome sequencing after maternal cell contamination. And teratogens are important: alcohol, some of the anticonvulsants, and alcohol is known really to impact the posterior part of the corpus callosum. And then antenatal infections, you would look for other signs of intrauterine. First, you take a history. You'd look if it's a second pregnancy. Very often we are able to sort things out by going and looking at the IgGs in the first pregnancy. That's a very cheap and a very easy way to sort things out. But if they don't have that, because most of the times only IgMs are done, I realize now. But if you don't have that, then you go into the history. Depending upon the gestation, you look at an IgG, IgM, look at other features on the antenatal scan. So I think in a nutshell, it's mostly this bit that I've.
So how would you counsel the couple, Dr. Ratna?
Okay, so that is the biggest challenge. Now for this case, it's 26 weeks. So you're already beyond your even extended limit of discontinuation. Because it's important to understand in pregnancy, you can do only one of two things: continue or discontinue. And to be able to make this decision, the gestation has to be, in your favor. And you need to have the various tests that we've talked about. So here it was isolated. It was a short corpus callosum, and they essentially have the same etiologies. I would do a karyotype or a microarray. I would counsel for exome sequencing. And what is the reason for that? So we know that if it's an isolated abnormality, and we've excluded all these, in 70%, the postnatal outcomes are good. And we will hear Dr. Saurabh Chopra more on that later, so I'm not touching about that. But if we do an exome sequencing, because they all have huge turnaround times which go up to 5 weeks, it can help in planning how you do your delivery, the mode of delivery. Would you do a cesarean for a fetal distress? And secondly, also the postnatal outcomes. Because if you do it after birth, then it's another, 6 weeks that they have to wait. And of course, look for infections. And when we do either the chromosomal microarray or the exome sequencing, the DNA is stored. And I would really like to impress on everybody to ensure that DNA is stored. Because very often, sometimes, if the baby dies or something happens, you want to do further testing and the DNA is not there, we've lost everything. So I think, yes. And the other important part is that if you don't find anything on a microarray or an exome, it is not equal to a normal child. It's very important to counsel that to the families. And we counsel in a way as to not, get them to be petrified of everything. We all have baseline risks. So you counsel on the fact that there is a baseline risk. And in about 10%, you'll find additional abnormalities after birth, which cannot be picked up on an antenatal scan. We have the role of an MRI, which has been also discussed. So all those things are there, and yet it could be a genetic disorder and the gene is not identified. So there are all these little complexities of counseling that have to go into our discussions with the couple. Yeah, so we've already discussed this, I think, while I talked initially.
Yes. So the most common is that if it's an extra you see something else or any other findings, the karyotype
It's important to do
is about
this.
18%.
Yeah.
Far more than what you would if you would just isolate, see the isolated complete or partial agenesis.
Yeah.
And
Poonam, your screen is paused.
sorry.
Yeah. So
Gaurika?
yeah, your screen had frozen, but now we are okay. We
Oh,
are on
I'm
the
so sorry.
slide
Yeah.
of the various kind of structural abnormalities. There is a
Yeah.
host of them. And I have not been able to read any common ones, but we could expect anything at times. So we have to evaluate them. Are they pathogenic? Are they variants of unknown significance? So there are databases like the Decipher and the UCSC, where we put in the genomic quadrants and see what are the genes inside, like you can see here, that are they associated with abnormalities of the corpus callosum, and are they significant for that phenotype that we see in the fetus. I think that's an exercise that needs to be done for every.
Are there any other
Yes, so there are more than
any
200.
other genetic associations?
Yeah, there are a large number of syndromes. In fact, this is one of the malformations which has a huge number of syndromes. And books say that they have more than 200 kinds of syndromes that can be associated with this. And these are some of the common ones. And Dr. Ramamurthy also showed us the acrocallosal and the Mowat-Wilson. But I also want to say that it's not necessary that all the syndromes would be associated with extra CNS or, anomalies beyond just the corpus callosum. Because see, if you see that Andaman syndrome, and we have 2 children under our follow-up for that who just had isolated corpus callosum. There were 2 boys. It's an X-linked syndrome. And none of the developmental delay or the neuropathy would be picked up on an antenatal scan, which again goes to reiterate that even if it's isolated, it's important to do. And even if the pregnancy is discontinuing, they're well within 24 weeks. It's essential to try and reach a definitive diagnosis, because it has great impact on counseling families for their reproductive risks. It has great impact for counseling other members who could be at-risk carriers. For example, L1 syndrome that you show us here, it's an X-linked disorder that is associated right from either corpus callosum abnormalities, ventricular megaly, to a full bone spectrum associated with intellectual disability. And their other female members in that family could be carriers and give birth to similarly affected children. So a definitive diagnosis is of great importance for that couple as well as for the rest of the family.
So right. So this pregnancy, there was no associated anomaly seen on imaging, normal karyotype and microarray. So she was referred to the pediatric neurologist for counseling. Dr. Saurabh, how would you counsel this couple who's already had MRI scanning and also had the amniocentesis with microarray and seen a geneticist prior to your visit?
Thank you, Dr. Poonam.
Hi, Dr. Saurabh.
Hi. So basically, I think Dr. Ratna has already touched upon the counseling, and I completely agree with her. But just to kind of reiterate things, I think the counseling would have to be in 2 major parts. So one part would focus on the outcome in a patient who's had just an isolated CC anomaly. Whereas the other part would also have to focus on the limitations as far as the scanning and the testing prenatally is there. So as we have already discussed, in about 5 to 10% and sometimes even larger number of patients, associated anomalies may be missed. And like in this particular case, we have not done a exome sequencing. So that would miss some of the metabolic abnormalities.
and some of the single gene disorders. So having kind of touched upon that, obviously in a soft way without kind of petrifying the family, we would go on to the outcomes. And here I would most likely want to kind of impress upon the family that, look, 70% of the times the neurological outcomes and the developmental outcomes are normal. There is a 30% chance that there would be associated neurodevelopmental problems. In about 8 to 13%, these developmental problems would actually be severe. But when we compare to sort of the baseline risks in, like Dr. Ratna was mentioning, the baseline risk of having neurodevelopmental problems in general in the population is about 12% in our country, and in certain areas it is much higher. So it's not like that even with a normal scan we would still have some risks of developmental issues. So so that would kind of give the family a perspective that how much is the true risk compared to the baseline risks. Besides that, the risk of epilepsy probably is much higher than the baseline, because baseline population risk of epilepsy is less than 1%, whereas here the risk of epilepsy is as high as 16%. But all in all, I would, if the child were in the less than 20 weeks or less than 24 weeks category, I would probably try to nudge them towards wanting to continue the pregnancy, but obviously the final decision would be the family's decision, because in our culture we know that sometimes even the slightest increase in risk is not really acceptable to the families. Thank you.
This is a pregnancy, a precious pregnancy with the IVF on the 3rd attempt. So informed consent would be necessary, giving all the pros and cons of both sides, yes. Which is where your counseling becomes very important. So could you just touch upon the MRI as well, Dr. Swara?
Yeah.
So if MRI is done, or yeah.
So as far as the prenatal MRIs are concerned, I think we've already discussed about the timing and the need to repeat it at a later date. Whereas as far as the postnatal MRIs are concerned, I would probably want to do it a little later rather than just as soon as the child kind of is born, because neonatal MRIs are difficult. Sedation in the neonate is more problematic as compared to a 3 or 4 month old baby. And unless there's an urgent need to do a scan, I would try to do it, say, around the 3 or 4 months age group. Because that's kind of a good time when we pick up many abnormalities well. The moment the child reaches, say, around 7-8 months, partial myelination actually obscures the clarity of the MRI. And then in that case, I would probably want to do it much later, say around 1.5-2 years of age, because that's when the brain again becomes fairly well myelinated and the structures are much better seen on the scan. And as you have kind of very nicely displayed in this slide, we do pick up things on the MRI which may not have been fully picked up on the ultrasound, with almost 5 to 8% of patients getting picked up on the MRI which were not picked up on the ultrasounds.
So this was also reiterated by the in a single center study where the 23 children with the agenesis were observed by one single neuropediatrician. And there was a standardized protocol in diagnosis and neurodevelopment assessment. And this series of patients or the children till 4 years were found to have a similar kind of 75% rate of a good or a favorable neurodevelopmental outcome. So to summarize, fine and gross motor control, language, and cognitive status can be impaired. Prenatal imaging is not always able to differentiate between complex and isolated cases. The postnatal imaging and thorough clinical examination is important. antenatally, should it is a team approach where the neuropediatrician should be involved right from the start as soon as we diagnose it and after seeing the geneticist. We should also reiterate that agenesis of corpus callosum, as is there for even normal children, they present with different degrees of impairment, especially the ACC with neurologic and the neuropsychological issues to it. So, Dr. Saurabh, would your counseling vary in hypoplastic or dysgenetic corpus callosum? Should that be the diagnosis?
So obviously the causes of hyperplasia and dysgenesis are somewhat different from agenesis and partial agenesis. But I think the data is still not enough for us to be able to do differential counseling in patients with dysgenesis versus hypoplastic corpus callosum. Obviously, as far as associated anomalies are concerned, I think there's some data that suggests that it might be higher in patients having hypoplasia or dysgenesis, but again, it's very limited. So I think as far as counseling is concerned, it would really not vary too much at this point.
Very too much.
In the next few years, more data would help us do differential counseling.
Thank you so much, Dr. Saurabh. Very helpful. So just to in the detailed neurosonography, there is a 20% chances that it could be falsely positive, that you're not being able to see because you've not taken the right plane. So if it's still not seen in the higher center, look for other CNS abnormalities, because 46% will have coexisting abnormalities. Offer the invasive testing. The CMA is the preferred one. Could think about the next generation sequencing, like the exome sequencing, if the geneticist thinks so. MRI would be useful, as 8 to 12% of the additional findings can be picked up on the prenatal MRI. Obviously, the prognosis is correlated with the associated anomalies. The poor prognosis with the, if there's associated anomalies versus the 75% near normal outcome. And isolated, we have touched in details, 75% is the good outcome. However, the severe disability also runs between 8 to 14% for the chromosome abnormalities. So, Dr. Saurabh, just briefly about how would you manage these kind of babies who are diagnosed postnatally, apart from what you just discussed? So just very quickly about postnatally, what else will you see?
Yes. So basically, I think the overall approach will remain the same, because it's the same baby. It's just that it has been delivered now. So, but we have advantages like doing ophthalmology and audiometry is something that we can do once the baby has been born. Also, as in neurology, we always say that follow-up probably is the most important thing that we do. And my teacher, in fact, used to tell that in neurology, if you don't understand anything about the baby, just call for follow-up and you'll probably make a diagnosis when you follow them up regularly. So that's something that's really important, and one has to impress upon the family that follow-up is important, because seizures may come up, other problems may come up which are not immediately apparent at birth. And obviously, just like we did in the prenatal setting, doing involving the geneticist, a pediatrician, a cardiologist may be required in these patients. And another difference once the baby has been born is that there's no super urgency to reach a genetic diagnosis in most cases. And families usually try to kind of take the news stepwise. And as Dr. Ratna and her team knows, I think I refer almost all my cases wherein I have even the slightest doubt of having a genetic problems to them. So I think involving a team approach is another important point when you manage them postnatally. I think that's about it. Recurrence risk, I think we have discussed already that in the isolated forms, it's about 2 to 3%. There are support groups if there are developmental problems or seizures, lots of support groups are available, things that we can help the family as a whole from a psychological perspective.
So support groups in the form of National Organization for Disorders of the Corpus Callosum, that's the US group, and then the Australian group of Australian doc. Similarly, there is a Corpal UK group where it's an Acadia disorders of the ACC and the Acadia group. So you have all this online, and there are a lot of information leaflets for the patients as well to give to the patients should they continue the pregnancy. Because it's very, very helpful for them to know that there are people like, there are other babies with the similar problems and they're doing quite okay. So the take-home messages are that there is an increased diagnostic yield with the CMA, about 6% more than the karyotype. MRI prenatal detects 8 to 12% more additional anomalies, and MRI postnatal detects 5 to 15%, and this should be told in the counseling, especially by as Dr. Saurav said, by the neurologist when they come to get counseling from them. And good prognosis has to be told in isolated cases, but they should be also told that there are limitations of scanning, as we have noticed. So over to Gaurika. Thank you so much, everyone, for the wonderful case 2 presentation. Gaurika, so I'll just take away my screen.
Yeah. So I'll start. That was a wonderful discussion. Now, this is comparatively a very simple case. And this is just to reiterate one point which we might encounter in our daily practice. So Dr. Alok, this patient is gravida 1. She does not have any significant history. She came to you 18 weeks crying because she has been told that her corpus callosum is small. This is what you have seen, and what is your opinion on it? This is 18 weeks and 3 days she's come to you.
So generally the patients, they come at 18 weeks for anomaly scan, and at times we find that the CASP is not that well developed. And once we see that the CASP is not that well developed, we look at the corpus callosum. And once we see the corpus callosum at 18 weeks, it may appear a little short than usual. Like it may not cover the posterior part is still developing at 18 weeks. And as Dr. Ramamurthy said, that we should wait till 20 weeks at least to see that the corpus callosum is fully developed. So in this case, we see that the corpus callosum is appearing short and it is not overhanging the tectal plate of the midbrain. But morphologically, it appears fairly good enough to me. The echogenicity is fine, and the various parts which I can see, they are absolutely normal.
So you assured the patient that let's not panic right now, let's wait, and you asked her for more time. So this is again another sagittal view.
This is I wanted to look at the corpus callosum at 18 weeks with a transvaginal scan and see that the corpus callosum looks fairly normal. And there are no other abnormalities in the brain.
Right. So since you reassured the patient, she got remarkably reassured that instead of coming back to you after 20 weeks, as you called her, she came back to you at 26 weeks.
The protocol is that we call the patient back at 22 weeks.
22 weeks, right? Yes.
Again, the patient
4 weeks, as Dr. Ramamurthy also said. Yes.
So the patient took her time and she came. I think I was glad that she took her time, because then I could see that the corpus callosum is very well developed and it is of the normal length. And the pericallosal artery, it is also showing the absolutely normalcy along the corpus callosum.
So what we wanted to tell over here is when we look at the biometry of the corpus callosum, all of us know that about 20 weeks, it is corresponding to nearly about 20 millimeters. But a lot of us do not tend to look at the measurements below that, earlier than that. And if you look at 18 weeks, it is just about 10 to 12 mm it is. So therefore, it does tend to appear a little small at 18 weeks. So as has been emphasized by our speakers before, and we are going to emphasize with this case also, that delaying, now that PNDT has lifted up the sword from her head, the delaying an anomaly scan to 20, 22 weeks would probably be a better idea, because you would pick up a lot more ultrasound findings and specifically brain findings over here. So the take home message for this case was only this thing, like we should try, if we are seeing the patient at 18 weeks, we should call them back at 4 weeks from there to confirm the diagnosis of, confirm that everything is looking fine, and not unnecessarily panic the patient that the corpus callosum is small or anything like that. And secondly, if we can once and for all do an anomaly scan at close to 20, 22 weeks, that is also a very good idea. We will pick up more abnormalities in that. So this is just one case. We do not have a case of this. This is what is a thick corpus callosum. So of late, this was first described in 1998, but there are not still too many studies about it. So thick corpus callosum is a short and a thick corpus callosum, and there have been a recent article, actually it came on in 2009, whether a corpus callosum, which is thick and short, whether it's an ominous sign or not. So over there, they also say, because that if there are associated abnormalities, the outcome might be bad. But if it's an individual finding, as an isolated finding, they also do not know what could be the significance of that. So here, when we pick up findings like these, we have to give very guarded prognosis to the patient and the family that we do not have enough data about that. Chances are, because it's isolated, everything might come out to be normal, but it can be associated with other abnormalities, and therefore we should look for it. So this is on to the last case. I will request people please not to go away. We have saved the best for last. This is a Gravida 3, Para 2, Live 1, 34-year-old female. First was a normal delivery. Second was a neonatal death following an early preterm delivery by cesarean for PIH. She had no other significant history. Her previous ultrasounds were absolutely normal. And Dr. Sheetal, she came to you for the first time at 25 weeks, 5 days for an ultrasound. Dr. Sheetal, can you start sharing your screen, please?
Sure.
So Dr. Sheetal does a lot of MRI work also. So she will take us through how from ultrasound to MRI, how she's made the diagnosis, which has helped us in counseling of the patient.
Slide?
Yes.
Can you see my slide?
Yes, we can. And we can hear you.
Good evening. Thank you, Team SFM, for giving me this chance to be amongst this August audience and panel. So this case referred to me at 25 weeks and 5 days, and on transabdominal, as you can see, the 3 lines instead of the cavum of the septum pellucidum. Here, I would like to stress one point, that when we say CSP, it's better to label it as a cavum of the septi pellucidi, because actually the septi pellucidi are never absent in a case of either partial or complete agenesis. If the septi are absent, the frontal horns would be definitely fused. So it is just the absence of the cavum of the septum pellucidum which has to be mentioned. So here, as you see in the upper axial sections in the ventricular plane, you don't see any cavum of the septum pellucidum, and you see that the third ventricle is high riding. But as you go down in the region of the phonesis, you see a structure which appears like the cavum. And this is a pseudo cavum. And unfortunately, even if we measure that, it falls into the category of a CSP ratio less than 1.5. So luckily, we have this sign which tells us that there is a likelihood of a partial agenesis, but this is not the cavum of the septum pellucidum. This is a pseudo cavum, and I suggest you to go through a very good article recently published in the Journal of Ultrasound Medicine by Gassani et al. And that gives a very good explanation of what a pseudo cavum is. Because of time constraint, I would not be going into the details. So this is what we saw on the sagittal section. You can very well see a structure which appears to be a CC, but unfortunately we were not sure. And on coronal correlation, we found that the anterior structure which you see here was actually just a potential space. And we could just see on coronal a very, very small CC. I have not used any coronal images also because there's a lot of discussion which has happened on ultrasound. So I'll directly go to the MRI images. So MRI did confirm the diagnosis of a partial agenesis of corpus callosum, but this was basically an embryological residue of a corpus callosum, which probably had formed very well in the posterior part. But if you see, we define the genu by a line which joins the mammillary body and the anterior commissure, and you barely see any structure in anterior portion. The rest of the posterior fossa structures were normal on biometry, and there were no abnormalities in any other cortical malformation seen. So this is a picture that we saw on coronal MR. Very clearly, it shows that there is no genu of the corpus callosum. You can barely see a sling-like structure, very, very faint. Possibly this could be the glial sling which guides the neuron, the axons, and there is no axonal guidance happening anteriorly. But as you see posteriorly, you see the structures. The body of the corpus callosum is very well seen. But what you see, going back to the first slide, you see that you do see a structure which looks like the splenium and campal commissure, but this is an embryologic form of corpus callosum. If you see in embryology, and I would strongly refer you to read the very good embryology by Charles Rebo in Neuroradiology 2010 article. So this is a primitive corpus callosum which has arrested in its dorsal migration, and it has got arrested at the level of upper part of the third ventricle. So this is likely to be the splenium, which has not undergone dorsal expansion. You don't see a genu, and you don't see the rostrum of the corpus callosum. So here, as I showed, these fibers could be a mixture of hippocampal and splenial fibers, but we cannot be sure whether splenial fibers are present. Hippocampal commissure has to be present if the splenium is there, or the vice versa cannot be present, possible. If there is no splenium, hippocampal commissure can still be present. On axial, as you can see here in the top image, there was a body of the corpus callosum. You see a small sling-like structure anteriorly, which could be the glial sling where the genu axons have failed to migrate. And what you saw as the cavum was actually the margins bounded by the thickened fornices. And you can very well see the thickened fornices with this small glial sling and this the cavum-like appearing structure, which is not actually the cavum of the septum pellucidum. You can see the anterior commissure anteriorly and the posterior commissure posteriorly. Documentation of all these structures by MRI or ultrasound is very, very important because it plays a very important role in counseling. After the T2 weighted images, we went on to do an MR prognostic score. So this is a very good score being suggested by Diogo et al. And recently published in the White Journal in 2021. And this MRI score takes into consideration the sulcation. So in this case, the sulcation was appropriate for the gestational age. So the score was 0. I will take you to the score after I finish this. And then we see for the symmetry or asymmetry of the temporal horns. In normal brains, there is mild asymmetry of the front temporal horns and temporal lobes. The right is more longer than the left. So this was normal in this case. The next thing we see for is hippocampal folding, which was normal in this case. And as Dr. Saurabh said, that there is a high chance of epilepsy in these cases, isolated cases of corpus callosum agenesis. So if you see a normal hippocampus with a normal hippocampal volume and a normal temporal lobe asymmetry, that very much rules out the possibility of developing an epilepsy because of isolated callosal agenesis. Of course, if there is a nodular heterotopia or anything else, that could give rise to epilepsy, but per se, because of isolated agenesis, the possibility goes down considerably. As you can see here, there is no significant ventricle enlargement. It is 9.45 and 9.1. And the other factor which we evaluate in the MRI score is the subplate or the lamination and the periventricular crossroads. So these are all the structures which cannot be evaluated well by ultrasound, and especially the hippocampi, the volume of the hippocampus, the subplate, the presence of the periventricular crossroads, and of course, these hippocampal folds. So MRI does play an important role, and Diogo et al. Has shown that if this score is less than 3, less than or equal to 3, the chances of neurodevelopmental outcome is excellent in these cases. And if it is more than or equal to 4, it is below average. So this applies to purely isolated cases. And when I say isolated, it means they do not have any other intracranial or extracranial abnormalities. The genetic testing has been done and it is normal. And in my case, if you see, there was an AFI which was above which was 21, which was a polyhydramnios, and the AC was at 93rd centile. So here I would be cautious in giving the prognosis to the patient, considering that this could be an upcoming overgrowth syndrome, or it could be some metabolic disorder also. But if this is an isolated finding of agenesis of corpus callosum, irrespective of whether it is partial or complete, the prognosis is excellent if the score is less than or equal to 3. The next step we do is we do a tractography. And tractography has changed the way we look at the corpus callosum and the understandings about the corpus callosum to a very big extent. So this is a normal DTI study of a normal corpus callosum, which we have done. And this is how a corpus callosum looks like in the fetus. There is no directional coding which can be applied in the fetus as compared to the adult, because we are scanning through the mother. So these are the normal callosal fibers you can see on the mid-sagittal section. And these are the homotropic connections going from one hemisphere to other. When I say homotropic, means they are connecting similar parts of the hemisphere on each side. So these are the fibers which are very well depicted in a normal CC. And these are the aberrant bundles which we saw in this case. So what do the aberrant bundles tell me? The presence of these aberrant bundles tell me that, in fact, indeed, this is a partial agenesis of corpus callosum. But in addition to that, what it will tell me is that I have these anterior U fibers, which I can see, which are connecting, giving me an anterior connectivity. I have these posterior U fibers, which are giving me a posterior connectivity. And I do see the probes bundles, and I do see interhemispheric connection going right to the hippocampus, which is likely to be the hippocampal commissure. So all in all, this will tell me that with the MR score of 0 and with the presence of probes bundles and the hippocampal commissure being confirmed, the chances that this baby is going to do well goes significantly high. Provided there is, as I told, no other abnormality detected, and we have done a full genetic workup of the patient. So in all, MRI does play a very important role. It does rule out several abnormalities which cannot be seen by ultrasound. Especially, it has been proven in our practice, we have seen that there are several posterior fossa abnormalities wherein you see that the vermis is normal on ultrasound, but you find an atrophic vermis on MRI. So this would take another whole lecture altogether, but this is the fact. You may not see the temporal part of the petrous part of the temporal bone, and inner ear abnormalities which may be associated with these findings may be uncovered only by doing an MRI. Small hemorrhages, early infarcts leading to corpus callosal destruction may not be picked up by ultrasound. So there are several other things, but due to time constraint, I'm not going to into the details, but the message is that MRI has to be done in every case of any brain abnormality, irrespective of the findings. And what holds importance in prognosis and counseling of these cases, documentation of the anterior commissure. It's not just the documentation of the CC which is important, and we are not concerned about whether it's a partial or a complete agenesis. Irrespective of the type of agenesis, if the anterior commissure, posterior commissure, hippocampal commissure has been documented, if you have documented probes bundles which have been proven to show better adaptive and social functions in these babies, and with an MRI score of less than 3, the outcome can be given said to be good. And this study has shown that the prognosis correct prognosis can be predicted in 95.2% of the babies. Of course, long-term studies would be needed to validate and to apply this to a large extent. But till the time we have the answers, we can at least start doing this so that we have a lot more cases to give an answer to the patients. Thank you very much.
Thank you, Dr. Sheetal. That was brilliant. And with this, we practically come to the end of our talk. So just a couple of take-home points. One is that we must insist on seeing the cavum, septum, pellucidum at every time when we are scanning the baby. Less than 18 weeks, it might not be visible, not visible beyond 37 weeks, but in between that, we must look at the cavum, septum, pellucidum. We must look at the normal shape of the cavum septum where it is longer than broader. Adding the anterior complex, magnifying that part will help us to further identify abnormalities of the corpus callosum. Once we pick up any abnormality, we must do a neurosonogram where we look at the sagittal plane, the 6 coronal planes and the 3 sagittal planes. look for associated anomalies. The neurosonogram can be done transvaginally if it's a cephalic presentation, and in breech, we will have to manage abdominally. Must look for associated abnormalities on ultrasound, specifically that of the hands and the limbs, which will not be picked up on MRI, even movement disorders, they won't be picked up on MRI. MRI to be offered in 2 stages, one at 20, whenever we are doing the diagnosis, because to confirm the diagnosis, because 20% can be false positive, and one later in pregnancy, not only for the MR prognostic score, also for the tractography, and also to see neuronal migration disorders, something which we will not pick up very well on ultrasound. Once we've done that, we must offer a genetic opinion. And as this slide has already been covered, so I will just go through it. A good MRI score will suggest a good neurodevelopmental outcome, with 75% being good outcomes. So without scaring the patient, telling them there might be a small chance that there might be some findings later in pregnancy once the baby is born. Most of the pregnancy.
Put it on the big screen.
Yes, sorry, okay, sorry. And we must offer a multidisciplinary approach. That means we must involve the genetist, the MRI specialist, the fetal medicine specialist, and also the pediatric neurologist over here. And most isolated cases have encouraging outcomes. So just to end on a little fun facts to just wake people up before they run away from the screen, that run away from here, that corpus callosum is larger in females, and that is what makes us more intuitive and helps us to multitask. Children who play multiple instruments, musical instruments, have shown areas where the corpus callosum becomes a little larger and makes them a little bit more intelligent and helps them to be more intuitive. And people have studied the brain of Albert Einstein, and they have realized that for his age, his corpus callosum was colossal compared to control groups. So with that, we end today. And if anybody is still awake and still around, we are ready to take some questions. So there are a couple of questions in the chat box.
I've answered quite a few of them.
Yes, exactly. So about the corpus, somebody's asked about the tip to know the length of the corpus callosum, whether short or normal. There are normograms which are available, and we have shown them. So you can just Google them. They're free articles. And there was one. I think that's it. We've practically covered all the questions. Is there anything which is
anything more? Yeah, I've answered them, and nobody's put any more questions yet.
Yes.
Except a reiteration that somebody wanted for the genetic stratification, so to say, for the investigations. I think Dr. Rekha Maratha wanted to know that on how we managed to skip the CMA and move on to exome and so on. I don't know whether Dr. Ratnapuri is still with us.
I am there.
Oh, wonderful.
I am there.
If you could repeat that for one of our listeners, please.
Yeah. So I always think it's a better idea to go forward with the microarray first. And like I said, we could, you always do a FISH or a QF-PCR to get quick answers. And if that is abnormal, you may not further do the microarray, but instead do the chromosome analysis, the karyotype of the couple, to evaluate for a translocation. Because if one of them is a translocation carrier, the risk of recurrence can be as high as about 30%. And, and otherwise, if it's just an isolated array abnormality with normal parental chromosomes, the recurrence risk is very small. And if the microarray is normal, then you go forward and you can order a exome sequencing. I hope that's clear.
Yes, thank you so much for reiterating that. Yes. And
Ratna, if you can touch on the reflex one as well.
Yes.
We had the answer.
So what I mean by reflex is, see, remember that every expenditure for our parents is an out-of-pocket expenditure. It's very easy to write all the tests, but it is quite a challenge to get them done. So how do we work in these constraints? We're not living in an ideal world. So we said that the common abnormalities are abnormalities of chromosome 13 and 14. So if we look at the 5 common chromosomes that we do, and we don't identify an abnormality, they are normal, then you go forward with the microarray. It's just a terminology that is used that, ask them to hold on to the microarray while you get your first report, which comes in about 3 days, 3 or 5 days. If that is abnormal, you don't take forward the microarray. But if that is normal, the first 5 chromosomes, then you ask them to do a microarray. That's what it means. Just doing it in a systematic, sequential manner. It's just a terminology of reflex microarray that is given.
Thank you.
So that one last question, and I don't know whether Alok will take this or somebody else, and that is the 11 to 14 weeks diagnosis, or 12 weeks plus diagnosis, if I may say so, of an agenesis. We know that Robert Lachman had a paper 10 years ago where he says that if you measure the distance, the size of the midbrain versus the distance between the height of the corpus of the forks, we might have some answers. So why aren't we using that 10 years down the line?
Yes, there was this paper by Lachman et al., and it showed that there was this interhemispheric IHF to midbrain ratio, I think.
Yes.
Right. Yes.
It showed that, but they had done a retrospective analysis of the images, and they had found that about 85% sensitivity in picking up the diagnosis of corpus callosum agenesis retrospectively. I am not aware of any prospective study as such.
True.
And in the case which I presented, which had this corpus callosum agenesis diagnosed later on, and when I went back to the images of the first trimester, it was absolutely normal. So it can be a useful tool in some cases, in most cases, but still it is not at present not very prevalent to use.
Yes, I think also what happens is that our settings are so different when we do a mid-sag for the nuchal translucency. We've really lost all our grayscale, and so we don't really get these delineations very well. And therefore, the corpus callosum would, the soft tissues would require a different setting with much more gain. And I think that's the reason why we're not able to actually do most of this when we do a retrospective study. But it'd be nice to be able to, while we're just eyeballing when we're doing our scan, perhaps we could take a look at that and see how small is the height of the forks. And that might be a clue to what we're looking at. But it's worth looking into as a research question for some of us who might be interested in it. And then,
could I say something, Dr. Khurana, here?
Yes, of course, Sheetal.
Yeah, so here I would disagree to this, because even if you're diagnosing it earlier in the first trimester, if you look at the embryology, the formation, the main base of the corpus callosum can be well appreciated by ultrasound only between 14 and 15 weeks. So it is very, very difficult to comment on whether the CC is present, even by looking at the forks, because it is still in the process of formation, and it's very, very difficult to comment on that based on the findings which have been quoted here. And the other thing is that anyways, we have to wait till at least 24 weeks to be very sure of it being isolated or associated. So rather than creating a panic amongst the parents at this early age, it is wise enough to wait till the 20-week scan, and where we have a real answer.
Yes, but indirect signs are fairly useful in a lot of conditions. And it might,
yeah, but in this case, I would disagree to creating any apprehensions in the family by just saying for research purpose we can do, but then I feel it would be a waste of time.
No, it would not be a waste of time, because if we reject that thesis that we cannot pick it up, then we do not do it. Tomorrow in a court of law, if someone says that you could have picked this up at 12 weeks and we don't have an answer, and someone picks up this paper.
Yeah, we do have an answer that the development doesn't happen at 12 weeks. The development
No, that is not true. It is an indirect sign of the future. And so people pull out these papers, and they've been quoted in the consumer forum, and people have been held up for this and said, why didn't you diagnose it earlier? So as a research question, we can reject our thesis. So it's not that we should reject everything just because we don't see it. Indirect signs are equally important. Also, we do know that if, for instance, I find an abnormal biochemistry, I would certainly look more carefully at my nuchal translucency. So it's the same thing, that I have a clue from my 12-week scan. And then there is this very, very interesting consideration on should we let our patients panic or not. We've learned today that a genetically normal corpus callosal abnormality does not necessarily have a good prognosis. We've also learned today that an isolation does not have a consistent prognosis. So is it for you and me to take guarantees for that fetus? or the panic of the patient to take over. So this is a dilemma that you and me must consider. Are we taking on things on our shoulders that we should not? Because Dr. Saurav Chopra made it absolutely clear for us that this is a condition where things could go either way and things could go terribly bad. So in our enthusiasm to try and save every life, are we really overstepping the fact that we should not explain to them the fact that we don't have the answers today? Yes, every day MRI is giving us progress, no doubt. But the fact remains that even the meta-analysis that we had cited about the pediatric prognosis, the D'Antonio meta-analysis, had clearly said that the quality of papers was so heterogeneous that we really could not come up with anything. So I think it is extremely important that if the patient goes into panic, that should be their problem, not ours. If they get into anxiety, they've got to learn to accept that. Because if you take that onto your shoulders, it's going to come like a bundle of bricks, like a ton of stone on your head, and then you're going to be stuck. So it's not that we should take this on for ourselves. If they're going to be anxious for 3 months, so be it. Then you're waiting for a one in a lifetime case to be decided 12 years in a consumer forum, for instance. So if they have to face this, they better be ready to face this. Life is not a bed of roses. And I think there is no harm in telling the patient that, look, yes, if you're not sure of your findings, make a note of it and call them back. Or we have the 16-week window. The 16-week window also reassures us that yes, things seem to be going all right, so it's okay. But a 16-week window to set genetics into motion is also very, very important. Our patients will look for second opinions. Our patients will look for genetics. Our patients will look for further investigation. And we have now facilitated their terminations of pregnancy by pushing the MTP Act. So if we've created such a beautiful situation for our patients, we must realize that we are giving them the best, but we can't stretch it anymore. So this business of not making our patients anxious, all of us at SFM are taking a relook, and all over the world we're taking a relook and saying that, look, if in Italy and in India, where the human mindset is the same, we really should not be giving guarantees to our patients and saying, chill, relax, go home, have fun, and I'll take on the responsibility because I am God. We have to stop playing God.
So on that note, should we call it an end of the
I
meeting?
think so, because we are at the end of our questions. Thank you.
I would like to.
Poonam and Gaurika, I have one follow-up for both
Yes.
of you. Since you've
Yes.
taken forward such a wonderful panel, why don't you spearhead us all putting our cases together with outcomes? Because there's so much of testing going on.
Mm.
And I think we need to bring it out as your activity. I mean, I'll help you, but I think it's, we've got so much within all of us who are here, and there are so many others who are not part of the panel and would contribute. I think we need to get in good multiple centers data, because there's no point in publishing 10 cases, 5 cases, 15 cases. It really doesn't happen. And it's okay. If there's only a microarray, that's fine. If there's a microarray and an exome, it's fine. If there's nothing and the outcomes are there, that's fine.
They have actually put on the 500 fetuses with just karyotyping. There are not many of them who had, the studies that had microarrays. So with that karyotyping, they put the entire series together. So I think we should take your advice seriously, Dr. Ratna. Gaurika,
I think so.
It's up to you too.
Yes, definitely.
I was looking for this.
Idea. Yeah. And Sheetal has an excellent collection. Dr. Ramamurthy has an excellent collection.
Alok himself
And
also has good
all
collection.
of those together. Yes.
All for his cases only. So I thank Dr. Alok, Dr. Ratna ma'am, Sheetal, Dr. Saurabh, and of course you, Poonam, and Dr. Khurana, you, sir, for the last words over here.
Thank you, Dr. Khurana. Thank you, SFM, for making me come, with Gaurika. It was such a pleasure being together and forming this discussion and this meeting. So thank you, Gaurika, and thank you, sir.
Gaurika,
Thank you all the panelists.
And a
Wonderful.
very special thanks to our clinician for making it so much more useful. Thank you, Dr. Saurabh Chopra, for being with us and giving us the long-term perspective. That was really fabulous and really helps us to put our thinking in perspective that, look, we can't take so much for granted.
Thank you. Thanks for inviting me. Thanks, everybody. Bye-bye.
Bye-bye. Thank you. Good night.
Good night.
night.